Welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this session is entitled Radiology Reporting, Accurate Service Documentation. This module is targeted to Level 1 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you were in a program other than diagnostic radiology, such as nuclear medicine or interventional radiology, please reference the REPLETE resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe documentation requirements necessary to obtain appropriate payment for common diagnostic radiology services, to identify opportunities to simultaneously improve care and enhance reimbursement in a systematic manner, to avoid common regulatory compliance mistakes, and to institute processes for team-based, continuous, improvement-oriented revenue management. Here are some additional resources listed chronologically for those who would like to learn more about the topics in this module. We talked in the last module about what do your reports look like? Are they meaningful, actionable, thoughtful, and detailed, ones that your referring physicians will use for the better care of your patients? Or do they look more like this, ones that in an era of open patient portals may lead to unfavorable Yelp reviews? As I continue to emphasize to you, there are many consumers of our reports. As we talked about and will continue to talk about throughout REPLETE, our coders and down the road external auditors will often be reading our reports. And so our documentation needs to be done in a manner that they too can understand. Structured reporting can help a lot, as will systematic informatics and team-based approaches to capturing necessary information. Without codes, we simply can't submit claims. It's what we need to do to get paid. It's all about the little boxes on the 1500 forms. All of our reports need to include information about not only what service was performed, but also why that service was performed. That information needs to get translated into ICD-10 and CPT codes, as well as a variety of modifiers and site of service and other codes that we'll discuss in future advanced modules. Again, we've talked about this workflow approach to this, following the money. In the last module, we emphasized a lot of the work before you provide your service as opportunities to capture medical necessity information. Today, we're going to be focusing a bit more on just what you do as a radiologist, your real-time interpretation, and how your documentation, what you actually do, will meaningfully impact the application of CPT codes for your services, meaning what service you performed, less about why you performed that service. And there are different rules under CPT for different modalities. In this module, we'll be talking about documentation for each of those: radiography, CT, MRI, ultrasound. CT and MRI fortunately follow the same rules. Increasingly, under PQRS, the Physician Quality Reporting System, and now MIPS, the Merit-Based Incentive Payment System. Again, things that we'll talk about in future pay-for-performance modules. It's not going to be about just documenting what we did, but how well we did it. Today, I will introduce some metrics about documenting quality as well. So let's start with radiography. And for radiography, the rules of documentation for CPT are pretty simple. Always document the number of views. Let me illustrate that with a couple examples. Here's a 4-view ankle radiograph. You see the radiologist report up above. How did the coders assign CPT codes? Well, coders are instructed for CPT coding to take a de minimis view towards CPT coding, meaning if there's several different code choices and the radiologist didn't document a higher level service, they're going to report that out as the lowest level service available. So in this situation, there were 4 views of the ankle, but no mention of the numbers of views. The coders would apply CPT code 73600, which translates to a national Medicare average fee schedule allowable amount of $8.17. If the radiologist simply said 4 views, his coder would have been able to appropriately assign a higher valued code, $8.51. Now you may say that's only 30 cents or so difference. Yes, you're right, but that's a 4% raise. And if your practice is interpreting 1,000 examinations a week or 10,000 a year or whatever numbers you all are doing, that adds up to serious dollars very quickly. A related question, can you document the types of views rather than the numbers of views? Of course. Frontal, lateral, and bilateral oblique, or something to that effect if you so prefer, would be fine. Your coders will be able to say, yes, that's 4 views. From a CPT perspective, however, it's not the specific views that matter, but the number that were performed and documented. Let's pivot to chest radiography. Again, complementary example here. 2-view chest radiograph, you see the report here, all looks good clinically, but no mention anywhere in the report or in the header of the number of views. So how would a coder code this? Well, again, they're going to take a de minimis view towards CPT coding. No mention of views, it's a single view until proven otherwise. CPT code 71010, $8.85, National Medicare Average Fee Schedule. Here again, simply stating 2 views would be enough to allow a coder to legitimately assign a higher value code. Saying AP and lateral or PA and lateral or whatever language you prefer, that would be fine. Your coders will be able to recognize that as 2 views. For CPT, though, it's not necessary. One important aside is that CPT codes refer to views and not images. It's a nuanced but important difference. And so if you perform a frontal chest radiograph on an extremely large patient, and it requires 2 plates to include the entirety of the chest, it's still only 1 view. That is, a frontal view. Let's pivot to CT and MRI. And here the documentation isn't on the numbers of views. 1,000 images on a CT scan aren't going to get you paid any more or coded any higher than 800. It's the details of contrast administration. And for CPT, there are 3 codes for nearly every body part for CT and MRI. Without contrast, with contrast, or a both, meaning pre and post. And that latter one includes multi-phase imaging if it included pre-contrast imaging. And here's an oldie but goodie. Clinical history, flank pain, possible mass on IVP. In this situation, a renal mass protocol examination was performed, pre and post contrast images, but the radiologist never mentioned whether contrast was administered or not. So how is a coder going to code that? Well, again, no mention of contrast, no documentation, essentially from the coder's perspective, wasn't performed. They're going to code that out as a non-contrast CT of the abdomen. You see the associated professional national Medicare average revenue associated with that. If that radiologist simply said pre and post contrast imaging, the coder would have been able to legitimately assign a higher valued code and result in a raise for that practice, legitimate revenue left on the table. Now, it's important to note that the volume of contrast administration is reportable to many payers separately as a supply charge. That's something related to technical rather than professional billing. We'll talk about the differences in professional and technical billing in a future module. Most health systems will capture that information through the radiology information system or sometimes their pharmacy billing system, using information that is entered by your technologist. But for the purposes of what we're talking about today, that is physician service CPT coding, documentation of contrast volume isn't necessary. It's really about whether contrast was administered or not, but capturing that information elsewhere in your system, other than your radiology report, will frequently be necessary. So the same rules for CT apply to MRI. Here's a brain MRI examination that was performed pre and post contrast. No mention whatsoever of that contrast in the report, however. So how does the coder code that? Again, de minimis view to CPT coding. It's going to be assumed without documentation to the contrary that this was a brain MRI without contrast. You see the National Medicare Average Professional Fee Schedule amount associated with that. There'd be a whopping raise if that radiologist just did a better job documenting the services that he or she performed. Let's pivot now to ultrasound. Ultrasound has a whole new set of rules. And for ultrasound, my recommendation is to utilize macros or checklists whenever possible. Why is that? Because for most body parts, and you see the examples listed here, CPT makes a distinction between a complete ultrasound examination of that body part or a limited ultrasound examination. Let me illustrate that for you with a complete abdominal ultrasound examination, CPT code 76700. CPT defines in the book for each of those services what's complete. Anything less than that is limited. So for a complete abdominal ultrasound examination, there's 8 things you need to mention in your report. You may say, well, what if the patient has a missing gallbladder? The rules here are pretty good. You get an A for effort. The gallbladder is surgically absent. We'll be fine. Simply state why you couldn't see it. The pancreas is obscured by overlying bowel gas. Again, that will count as if you evaluated the pancreas, because you did. You tried to. You don't have to see these organs. You just have to document, if you can't find them, why you didn't. Now, the most common organ that's neglected in documentation is the spleen. You miss mentioning just the spleen. You don't get 7/8 payment. This goes from a complete examination in a binary manner to a limited abdominal ultrasound examination. You can see the National Medicare Average Fee Schedule allowable amounts here. It's a not insignificant difference between the two. And so this is something that you really need to pay attention to. It happens frequently in our practices. This is some work we published in the JCR several years ago, looking at over 250,000 abdominal ultrasound examinations for a variety of different practices across the country. We used a couple different natural language processing models here. The details aren't as important as much as the point that in anywhere from 10 to 20% of abdominal ultrasound reports, radiologists failed to mention at least one organ, resulting in a lost legitimate revenue of as much as 5%. So again, this is one of the reasons I'm a big fan, and I think others are big fans of using templates. Here's an example of a template that I used in my former private practice. A lot of other practices will use more laboratory-oriented looking reports where there'll be different bullets for liver, spleen, gallbladder, and the like. My personal preference at that time was to go more prose-oriented. I've evolved in my reporting preferences since then. But the bottom line here is these templates will help me make sure that I document all 8 of those things, and I can just simply tab out to describing the biliary ductal dilatation or the renal stone or the hydronephrosis or whatever the case may be. Again, one of my messages to you here, I'll encourage you to try to remember who's reading your report. It's not just about you as a radiologist understanding what you think you said. It's not just about your referring physicians understanding these from their clinical perspective. It's also about the people who assign CPT codes and the people who may down the road audit your claims. They're going to follow the CPT rules if you're using CPT to bill for your services, and you will be. Here's the rules of CPT. If you look at the front of the book, the rules are pretty specific. Your coders are instructed to select the name of the procedure or service that accurately defines the service that was performed. Specifically, they're told, do not select a CPT code that merely approximates the service provided. If no such procedure or service exists in the book, then report the service using the appropriate unlisted procedure or service code. Meaning if they can't figure out what you did, what you said you did, they're effectively going to put a question mark code in that blank on your form, and that's probably not going to get paid. What does that mean in practice? In radiology, there's a lot of terms that we use in a colloquial manner. MR enterography, CT urography. You may understand what that means in your practice. Your referring physicians may as well in their practices, but your coders don't necessarily understand those things, particularly since there's still some lack of uniformity in what those terms mean. So templates are your friend. Here's an example from a practice where the urologist and the radiologist both all understood what was entailed by the term CT urography in their community. They knew what they each wanted of each other. But it was a scenario where the coders and payers were pushing back. This was an ambiguous term to them. So with the input of those referring urologists, the radiologists worked with their billing and compliance teams to craft language that reflected the ordering and workflow patterns that were in place. What does CT urography mean? Let's make sure that we explicitly state that in the technique section of our report, and they implemented that into a standardized report. Efforts like this make sure that reports are most meaningful to not just radiologists, not just referring physicians, but all various readers, particularly the coders and billers. Now, some radiologists will push back at this and say, well, that information's already in my report. I can imply from this, because I'm a board-certified neuroradiologist, I mentioned L3, that this was an MRI of the lumbar spine. I stated that there was no epidural enhancement, and the only way you can comment and make a statement like that is if you had pre- and post-contrast imaging. Sure, if you're a neuroradiologist, you can probably rest on that impression, but in reality, there's other consumers of our reports, particularly in this setting where the hospital header was wrong and said thoracic spine. The radiologist could have simply fixed that by documenting a technique section. Where in the report does it explicitly state lumbar spine MRI, pre- and post-contrast? 2 sentences in a standardized template in a technique section would have avoided a lot of the misunderstandings in this report. And as we move forward, both with our health system initiatives, but also in Replete, we will need to be thinking about preparing for new payment models. Pay for performance, P4P, is something you'll be hearing a lot about from me and others. Over the last decade, we in radiology have been working through in the PQRS, the Physician Quality Reporting System. And hopefully this list here are things that are familiar to you in your practice, things that you're being asked to document and are documenting to be able to meet pre-existing quality metrics from CMS. Under the Merit-Based Incentive Payment System, MIPS, again, something we'll have several modules on later, there will be many more quality metrics which will influence physician payment. And for many of those, specific documentation language will be critical. Here's an example of something for central line, something I used to do a lot in practice. My templates included brackets to remind me to document maximal sterile barrier technique and to document my fluoroscopy time. Why? Because they're PQRS metrics that impact my payment. And we're not talking about chump change here. Under the PQRS system, in its very early years, and this has evolved since and will continue to evolve, radiologists who received a bonus from CMS received as much as $3,000. That's a lot of money. But only a quarter of radiologists qualified for that bonus. What does that mean? About 75% simply didn't employ templates in their practice to allow them to be successful under this documentation reporting system. We were on a trajectory with that, and time will tell whether our projections were correct in 2006 because Medicare data is still not available. But we were on a track for 75% or more of radiologists to collectively see penalties of over $100 million for our profession. Under PQRS, penalties and bonuses were only in the 1% range. When MIPS is fully implemented, bonuses and penalties will adjust your Medicare payments upward or downward by as much as 9%. So accurately capturing quality metric information will be increasingly important. Templates are going to be your friend, from you reporting things to making sure that your coders understand what you did. In summary, your revenue team can only assign correct codes if you let them, and that means you have to document in your report what you did. For radiography, dictate the number of views. For CT and MRI, dictate the details of contrast administration. For ultrasound, use a checklist. And for pay for performance, the rules are varying, and this is one area where templates will particularly be our friend. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.